Sorry, just got behind in the phone call to start the recording, to go live on YouTube.
Which sir, Dhiren sir has come. Small inauguration and then Jason.
Yeah. Permanent? Permanent, say. Permanent has joined.
Yeah, Permanent sir, unmute and photo, video please. Yeah. Dhiren sir also doing.
Amish, continue.
Okay. Good evening, everyone. And thank you for coming on the second part of Back to the Basics. So like how last time we concentrated on fluids and electrolytes, this time on this weekend, we're just going to concentrate on nutrition, of which the first talk today is on parenteral nutrition, for which we have a good speaker, Dr. Shasha Verbruggen, who is a PhD in nutrition and critical care. So sadly, Shasha had some family emergency, so he could not come live, but he was kind enough not to cancel it last minute, and we have recorded his talk and we are going to play his recording of the talk today. At the same time, we are really privileged to have Dr. Prasad with us, who will be chairing the session today, and later on his team will be following with the case presentation. Before taking much of the time, I would now ask Dr. Dhiren to say a few words.
Amazing work you are doing, and your team is doing fantastic work, and it's very difficult to arrange and difficult to get time for all these academics, and presently it's a pretty heavy season as compared to COVID. That time we all were free. So what I could say, best of luck, and it's amazing work. You and your team, Dr. Sheikh, Dr. Lakshmi, Dr. Parmanand, awesome Mumbai team, and best of luck.
Thank you. And thank you for all your support. For both Dhiren and Dr. Arun have been a very valuable support for what we are doing it. So briefly, before I hand over to Jason, who is the master of the ceremony, I just want to give a brief idea about Shasha. Shasha, I know for more than 10, 11 years. I met him about 2008 during the ASMIC conference in Rotterdam, where he is from. And that time he was talking about the glucose in ICU, and in that era, we all were thinking of glucose, and we were planning to do in fact, Dr. Duncan from UK did a multi-center trial on CHIP, which was a glucose in critical care. And since then, he was always passionate about nutrition and metabolism in critical care. He had just finished his research fellowship from Texas Children, and he had come back. And after that, he did a PhD. He did a PhD about protein metabolism in critical care in Rotterdam, which took about 4 years. And he's a person whom we would, anything in critical care in Europe, we would ask his unit to, anything with nutrition or metabolism in critical care, we would always take his reference and his opinion for that. So it would have been really great to meet one of the really upcoming star of critical care in the world stage. But I would now hand over to Jason to take forward. Thank you.
Good evening, everyone. It's my immense pleasure to actually read out the brief biodata of the speaker, Dr. Shasha Verbruggen. He works as an attending staff in the Department of Pediatric Intensive Care in Sophia Children's Hospital, Rotterdam, which is located in Netherlands. He is a clinician scientist focusing on nutrition and metabolism in critical illnesses, with a special interest on long-term consequences for critically ill children. In 2007 and 2008, Dr. Verbruggen worked as a research fellow in nutrition and metabolism at Children's Nutrition Center and the PICU of Texas Children's Hospital in USA. And then he returned to the Netherlands and he started his work in the pediatric critical care at Sophia Children's Hospital. He has done his PhD on protein energy and their interactions in critically ill children, completed in December 2010, together with Professor Dr. K.F.M. Justin, and established a role for nutrition and metabolic research unit and he also continued the research in nutrition and metabolism in critically ill children at the same hospital. Since 2018, he is the chair of the metabolism and nutrition section of the European Society of the Pediatric and Neonatal Intensive Care Unit. So we are very lucky actually to hear him out. I invite Dr. V.S.V. Prasad sir, the teachers of the teacher. I think sir does not need any introduction, briefly, sir is the director of the PICU Senior Pediatric and Neonatal Intensivist at Lotus Children's Hospital, Hyderabad. Sir is the one of the most experienced senior pediatric intensivist and neonatal intensivist who has actually contributed in a great way to create the sensitization about the branch. He's the teachers of the teachers, and sir, welcome. So I invite you to actually moderate this session. So I request Mr. Bhavik actually to start the video.
Bhavik, you have to play the play button.
Amish sir, he is doing.
Okay.
Open to him.
Oh.
Is it audible now?
Good evening, everybody. My name is Sascha Verbrugge. I'm a pediatric intensivist in Rotterdam, the Netherlands. And today I want to talk about parenteral nutrition in the PICU. So as we all know, sick children are very difficult to feed. And if you look at these pictures, then of course all these children are sick, but we're not going to talk about the two children below. We're only going to talk about really sick children during the acute phase in our PICUs. Because we all know that being undernourished in the PICU is associated with increased morbidity and even mortality. Think of infections, longer length on the ventilator, longer duration in the PICU as well as in hospital. But it also counts when you are being undernourished in the PICU. So when you're losing weight in the PICU, you also have an increased association with morbidity. One of the most important studies is the PINS study from the group of Neeraj Mehta in Boston. They looked at energy and protein prescription in the PICU, and what they found was that if you do not reach your targets of energy, this is associated with a lower odds of a higher odds of mortality. This also goes for protein. So if you do not reach your protein targets in the PICU, this is associated with an increased risk of mortality. However, we need to keep in mind that these association studies, so these observational studies, do not show a causality, meaning that, yes, patients with a higher chance of dying are probably also sicker, and thus they have a lower odds of adequate nutrition. This can be seen in this table, a figure also from the PIN study. So patients or children who were sicker at a higher severity level of sickness also did not reach their protein targets. So we need to be careful to make it as a causality. Because when you're undernourished, yes, you have a worse outcome. And that's why worldwide we all agreed to feed early and to start as high as possible. And if this can't be reached with enteral nutrition, we were used to do this with parenteral nutrition, already early and high, as we have shown already 5 years ago in this worldwide survey. We got a response of more than 156 PICUs, also several from India, and they showed that 60% of PICUs started parenteral nutrition within 48 hours, and already 20% even started parenteral nutrition within 24 hours in PICU. And we know that parenteral nutrition has certain potential side effects. I want to refer to this beautiful review already from more than a decade ago by Ziegler in the New England Journal of Medicine, if you want to read it. But there are several side effects which have been associated with parenteral nutrition, being immune disturbances, infections, electrolyte disturbances. And we know that the composition of parenteral nutrition for critically ill children lacks scientific support and actually appears to be partially based on convenience. So how easy it is to solute certain products in their fluids. So what we did is we set up to do a randomized control trial. And I'm going to show you the rest of the presentation, the results of our parenteral nutrition study called PPANIC. The P stands for pediatric because this was also done in adults. This was a multinational RCT which included 1,414 children in Leuven in Belgium, Edmonton in Canada, and in Rotterdam in the Netherlands in my own PICU. And what we did was we randomized these children to receive parenteral nutrition early, so within 24 to 48 hours when enteral nutrition was not sufficient, or we would withhold the parenteral nutrition during the first week in PICU, even if the children were insufficient to get enteral nutrition at all. So even in children who did not get any enteral nutrition during the first week. And what we found was actually that not providing parenteral nutrition during the first week accelerated recovery, improved the chance of a live discharge, and saved costs. So withholding parenteral nutrition during that first week, accepting low nutritional intake during the acute phase of critical illness, showed that we had fewer nosocomial infections. It went down from almost 19% to 11%. A shorter stay, both in the PICU, as this figure shows, but also in hospital, and a higher likelihood of an early life discharge from the PICU as well as from the hospital. It also saved more than €7,000 per patient, and primarily by reducing nosocomial infections, as you can see in this graph. So when you do not start parenteral nutrition during the first week, these children had much lower chance of getting nosocomial infections, which really reduced their costs in the PICU. Well, of course, we got a lot of comments. One of the comments was saying, okay, but you are overfeeding your patients. You do. What about the patients who are already undernourished in your PICU? And what about the younger infants, the neonates? Well, first we set out to look at these undernourished patients, and in the PPANIC study, there were approximately 290 patients already undernourished or even severely undernourished, meaning they had a Z-score of less than 3 SD. And then we went to look at the results. So we also found that being undernourished was indeed associated with a worse clinical outcome. So these children who entered our PICU and were already undernourished had a worse outcome. However, withholding parenteral nutrition in these undernourished children was still clinically superior. Less nosocomial infections, shorter duration of stay, shorter duration on the mechanical ventilation, shorter duration in the hospital, as you can see in these graphs. So on the left, the number of new infections in these undernourished patients. So the effect was even larger than in the group as a whole. Same goes for the days in the PICU as well as the days in the hospital. Then we looked at, what about your weight deterioration? Because if you feed these patients less during the first week, they probably lose more weight. And we know that losing more weight was in other studies already associated with even a worse outcome. Well, indeed, if you had a larger change in weight z-score, so if you lost more weight in the PICU, you had a higher chance of getting new infections and you had a lower chance of a live PICU discharge. However, again, withholding parenteral nutrition, lower chance of infections, higher chance of a live PICU discharge. And what we found was that withholding parenteral nutrition was not associated with a change in weight z-score. So these children were actually not losing more weight than the children who were receiving parenteral nutrition during the first week. Then the second group, the term neonates. Again, we got a lot of critics from the neonatologists in the world saying that it was almost unethical not to provide parenteral nutrition early in these neonates. And what we found was in more than 200 neonates, of which 145 were neonates less than a week old, and even 45 neonates who were newborns, so who came into the PICU on the day they were born. And again, we found the same results. So less new infections, even in term neonates who did not get parenteral nutrition. And interestingly, the effect was even larger in the most young neonates. So the effect looking at the withholding parenteral nutrition, these red bars, was comparable over all age groups. But providing early parenteral nutrition within 24 to 48 hours actually increased the risk of new infections even higher in the very young neonates. And the same effect goes for the duration of PICU stay. So also the term neonates are to be protected when you withhold the parenteral nutrition during the first week. And the effect was even higher in the youngest neonates. This table shows the group of neonates who did not receive any enteral nutrition during the first week. So you might think of congenital diaphragmatic hernia or gastroschitis. So neonates who did not receive any enteral nutrition and also were randomized between early or late parenteral nutrition. And of course, we had a lack of power because of only very small numbers. You see here, 38 neonates could be included in the secondary analysis. But still, you see a trend that even in these neonates, not providing parenteral nutrition was still better. And for mechanical ventilation, it still was statistically significant in this very small group. So, could it be possible that a fasting response due to lower macronutrient intakes was actually beneficial? Well, yes, because what we found was that an increased ketogenesis during that first week, which peaked on day 2, was actually partially explaining the effects we saw in the PPENIC study. So how about protein? Because if you leave out protein, we already know that these patients have a huge amount of muscle protein catabolism, which has a very large impact on their outcome. And we know that this is caused by critical illness, by inflammation, by endogenous and exogenous factors such as cortisol, catecholamines, but also immobilizing our patients. These amino acids that are used for acute phase proteins to make cells for the immune system, but also burned as energy. So for decades, it has been the thought that if you provide large amounts of amino acids or proteins, stop muscle protein metabolism. However, There is no muscle protein anabolism during critical illness when you are feeding more energy or motor protein to these patients. So it does not work. But does it mean that it doesn't cause any harm? Well, it actually most certainly does, because in our PPENIC study, we found that the amino acids explained the harm we found in our PPENIC study when you feed your patients parenterally during the acute phase. First, the new infections, and this is a complex figure, so let me go into it. In the different colors, you see the three macronutrients: glucose, amino acids, and lipids. Because this was a very large study done in three centers who all had their standard nutritional protocol, we could very specifically look into these three macronutrients and investigate which of these macronutrients was actually causing the harm we found in the parenteral nutrition. So in the top of the graph, this is the harm, and below this line is benefit. And what we found was that not glucose or lipids, but actually the amino acids explained the harm we found on the new infections. Same goes for the ventilatory support. So the likelihood of live weaning from the ventilatory support was harmed by increasing amount of amino acids during the first 7 days. Same goes for the live PICU discharge. Harm because of amino acids. Actually, increasing amount of lipids might possibly be beneficial. So this suggests that an early administration of amino acids, not glucose or lipids, could explain the harm by the early supplemental parenteral nutrition in the children. And we even found a dose response that showed that the amino acids were already harmful in these very small doses. So we need to be very careful by actually thinking of providing more amino acids and more protein during the acute phase of critical illness. So why could less nutrition be better? Why would less macronutrient supplementation during the first week be better? But when you're critically ill, you have a lot of damage on cellular level also. So there's a lot of what I call waste. Mitochondria, which are disposed of, cellular damage, dead bacteria, viruses, and all this damage induction needs to be taken out of your system. And a process called autophagy actually does this. It's a damage removal system, which actually recycles all these cells and all this damage and making new amino acids to be used by the body again. And when you feed your patients, so nutrients, but also anything which is anabolic, like growth hormone, like insulin, but especially also certain amino acids, such as leucine, they actually block the autophagy process and actually increase the immunological disturbance and muscle wasting in your patients. This was already very nicely shown in the adult study. So in the counterpart of our PPENIC study, you have the EPENIC study, which was done in adults, and they showed that the early parenteral nutrition actually did not reverse muscle atrophy, but actually made it worse. There was more macroscopic muscle loss, also in the quality, and increased fat content in the patients who were receiving the amino acids early during critical illness. This was caused by inhibition of autophagy in these muscles, as you can see in this picture. So the more parenteral nutrition that was provided to the patients inhibited autophagy, and that actually made the muscle status worse in these patients. So we need to think of critical illness actually as a process over time, because what I have been telling you now is probably very likely to happen in the acute phase. So maybe in acute phase, you should feed differently than in the chronic or even recovery phase, because hormones are completely different during the acute phase than in the recovery phase. And we probably should also feed differently during these phases. And as you can see here, I'm not stating which time or hours patients are actually going into the certain phases, because at the moment we have no idea how to diagnose these phases. But we are getting more and more sense that during the acute phase of critical illness, you should probably feed less calories, less protein and amino acids. And the risk of overfeeding is very high in the acute phase. Whereas in the recovery phase, the risk of underfeeding is probably higher. When patients are actually using their muscle and mobilizing, you should probably give more calories and more protein to actually start recovering from the critical illness. Now, summarizing, I showed that withholding parenteral nutrition during the first week, accepting a low nutritional intake, accelerated recovery, improved live discharge, saved cost, which was probably caused by an increased fasting response during the acute phase of critical illness. This was also the case in undernourished patients, it's also the case in term neonates, and I'm now going to show you that it even improved long-term follow-up of these patients. We did a long-term follow-up of these patients 2 and 4 years later, which was published in 2018 and 2020, and I'm going to show the slides mostly connected to the 2-year follow-up. What we found was, and let me go back for one slide. So not only did we look at the patients, but we also had more than 440 healthy controls, of which a large part were siblings and relatives of the patients, and another part was unrelated, but it were close to their age and social economic status of the patient. What we found was that the health status was not affected, mortality was not affected, growth was not affected, but it actually improved certain domains of their neurocognition, as you can see here. Inhibition was improved, working memory, metacognition, the overall executive functioning, some behavioral problems, and even visual motor integration. And I can imagine that you don't know what these certain domains do, but let me give you some examples. That impaired cognitive ambition actually is the impaired ability to suppress the immediate response of these children in classes, but also at home. Working memory is, of course, very important to perform multiple step tasking, both at home as well as in school. The impaired metacognition, meaning that the child is not capable of evaluating him or herself in this situation at a certain time or place where they are at the moment. Externalizing problems, you need to think of antisocial and aggressive behavior. Impaired visual motor integration, so the impaired eye-hand coordination. And all these things were improved in patients who were not receiving parenteral nutrition during the first week. And 4 of these domains actually were not different statistically as the healthy controls. One of the examples here, so the blue lines are the scores of a certain test in healthy controls. The red lines are the PICU patients who received parenteral nutrition early during the week, and the green lines were those who were withholding parenteral nutrition during the first week. And of course, you can still see that they are different from the healthy, although statistically they were not different anymore. So how could we explain this? How could we explain that a few days in the PICU of not receiving parenteral nutrition actually impact the long-term outcome? We think this could be explained by epigenetic changes. And epigenetic changes are alterations to your DNA, of course, not the sequence, but when they are switched on or off. And this could be with DNA methylation. There are other examples of epigenetic changes that alter your phenotype actually. We specifically moved into and focused on DNA methylation as an on or off switch of your DNA. And how we did was the following. Of course, we had all these patients and we looked at the DNA methylation on admission as well as on discharge. And then we had this large group of healthy children. Of course, we also looked at their DNA methylation. And the differences between these two groups, we completely discarded because, of course, they could be because of pre-morbid conditions. A lot of our patients in the PICU, of course, did not become ill overnight, but they had a certain condition or history already before they entered the PICU. So we discarded all these DNA methylations. Then we looked at the DNA methylations. We were still comparable and then changed over time. So during the PICU admission. And then these changes, again, compared and said that these were de novo DNA methylation changes that occurred during the PICU stay. And then, of course, we could do the same thing with patients who did or did not receive parenteral nutrition and stated, okay, the changes between these patient groups said that there is abnormal DNA methylation evoked by early parenteral nutrition. And then, of course, we could look at these changes, both from PICU versus healthy, as well as early versus late parenteral nutrition, and assess these and compare these with their findings at the long-term follow-up. Now, we used more than 850,000 CPG sites, and we could look at, which were, of course, more than 300,000 CPG sites already different between the PICU patients and the health controls, which we completely discarded. Then, looking at the patients and the healthy controls over time, we found 159 CPG sites which actually changed during PICU admission. And we found 37 of these CPG sites to be differently methylated between the early and late parenteral nutrition group. So, looking at the long-term follow-up, the CPG sites between healthy and the PICU patients explained 42% of the outcome variance between the groups. And for the 37 CPG sites of the early versus late parenteral group, also again explained a very significant part of the outcome variance in our long-term follow-up. Making my conclusions that withholding parenteral nutrition during the first week of critical illness improves short-term outcome in children and term neonates independent of their nutritional status. Early parenteral nutrition is not capable of changing weight deterioration during the PICU. Early administration of amino acids, not glucose or lipid, could explain the harm caused by supplemental parenteral nutrition in critically ill children. And a fasting response through increased ketogenesis and also probably activated autophagy might potentially be beneficial during the acute critical illness. Withholding parenteral nutrition during the first week of critical illness does not cause any harm on health status or growth at long-term follow-up 2-4 years later, and improved certain domains of their neurocognitive development. And withholding parenteral nutrition during critical illness altered the DNA methylation, which statistically explained part of the beneficial impact on neurocognitive outcome we found at follow-up. With these conclusions, I want to have you one more slide of telling you in our PICU how our protocol looks out. So the first week, we only feed enteral nutrition. We do this post-caloric or gastric. There's certainly not enough evidence to say that you should feed post-caloric or gastric, and we feed both capable when a patient has a huge amount of enteral intolerance. We try to feed post-caloric, but the first choice in our PICU is gastric feeding. We start early. We try to feed our patient within 6 to 24 hours, and we increase slowly. On indication, we use energy or protein-dense solutions. You need to think of patients who are fluid restricted, patients who are also intolerant to feed, who are a lot of vomiting. We use hydrolyzed formulas, and on admission, we start with intravenous glucose alone, but less than usually is in parenteral nutrition. And we provide intravenous micronutrients. So you need to think of vitamins, trace elements, electrolytes, when enteral nutrition, of course, is insufficient. And only after the first week, we start with full parenteral nutrition, inclining during the days to come, which approximately looks like this. So the first 7 days, only enteral, trying to incline, so to actually to feed a patient more during every day, and focusing on trying to reach the resting energy expenditure during the first week, and then inclining after the second week, if necessary, with parenteral nutrition. With that, I want to thank you for your attention and conclude my presentation for today. Thank you.
Good evening. Really interesting observations by Dr. Shasha. We as intensivists, we are more prone towards starting parenteral nutrition early if you're not able to use the enteral route. But some of the observations which he has mentioned is really amazing, where withholding parenteral nutrition for the first week can actually have beneficial effects long term, especially in neurocognitive and other benefits. In ancient Indian customs is when we all know that when you are sick, you don't expect to eat much, and there's no problem with that. There may be some science behind it, but our ancient physicians and our customs were not able to explain why. It's really interesting, but so really a wonderful discourse by Dr. Sasha Verbruggen about nutrition in the ICU. Any comments or questions?
Lakshmi, any questions? Anything?
No, there are no questions here in the chat.
So it's very important what he's mentioned, and this is the same thing what we had mentioned when we did our guideline when we were in UK. When I did my guideline in UK in 2012, that was a time where we showed that, we should not feed for the first 5 to 7 days. Obviously, that was based on the sickness and the inotrope needs, and it was a cardiac and ECMO level 4 unit. And we were finding that the resting energy state was requirement was quite low compared to what we are used to. Okay, so when the child is sick, you use the indirect calorimeter. It shows that you need on the first 3 to 4 days, right from Rogers 2000 till 2004 by Rudolph in pediatric critical care medicine, they've shown that the resting energy requirement is about 40 to 65, 70 only kilocalories per kg. And that is easily given by your basic nutrients. And so that was the time where we decided that, in 2012, though we did not have this randomized trial, which Shasha did later, that for first 5 days, we would not start TPN. Obviously, there were my colleagues who wanted to start early. So we somehow agreed that between 4 to 5 days, we'll wait on starting the TPN. And so it was quite good to see that the evidence has come now that, the first week we should not be. Also, at the same time, another thing we were seeing was in the retrospective trial, we were seeing that those who were starting TPN in the first 3 to 4 days were getting more infection. Whether it was there or it was not there. And that was one of the reasons. Also, and most of the level 4 NICU, PICU with the cardiac ICU were 60-70% were the neonates. So it was quite contrary to our neonatal training where we say that start TPN everybody. And so what I used to tell everybody was that the newborn is not a bigger preterm baby. So how we say that children are not small adults, same thing, I think the full-term babies are not a bigger preterm baby, and when they are sick, it's totally different. So, it was quite different for that.
These are interesting observations, Dr. Amish. Actually, the pediatric population, the very sick children, we tend to start TPN a bit early, isn't it? Within 24,
Yes.
48 hours provided. Ideally, I mean, if you're able to use the enteral route, once you're stable, you can start the enteral route. That will be ideal and also safe for the patient. But in case, for any reason, you're not able to use the enteral route of nutrition, we generally think of at least by 48, 72 hours to start some form of parenteral nutrition. That's more or less traditional, but we really don't know why actually withholding parenteral nutrition for, as per Dr. Shasha, close to a week may be actually beneficial. He has a point in the studies which he has described where if you start early, there's a risk of infection. Naturally, with a central line, indwelling central line, the risk of sepsis is going to increase. But we probably have to balance somewhere. We really don't know exactly at what point we need to start parenteral nutrition. We'll discuss that, I think, in due course, but interesting observations and actually a lot of thought-provoking practices which we need to introspect as well as discuss and then try to have more data before we can move forward and make any sort of recommendations long term.
Sure.
Any questions from the audience?
Vishnu, any comments?
Dr. Vishnu, yes.
Yeah, Miss, we also see the same phenomena. If we start parenteral nutrition in the post-liver transplant patients or post-liver surgery patient, it actually increases the chance of risk of infection and the SIRS syndrome. So what we tend to do now is the ERAS protocol. So where we start enteral nutrition as early as possible within 6 hours of the post-surgery, and then continue to give the enteral nutrition, the smaller the amount, whatever maybe it is, but start early, and that is how we are seeing the enhanced recovery in these kids. And we are able to discharge the post-Kasai patients within 5 days or post-liver transplant within 7 to 8 days. So the enteral definitely better than the parenteral, and withholding parenteral is very important, that even after the GI surgery, we can start enteral nutrition if the anastomosis is good and there is no chance of leakage, then why not to start? It is not necessary to pass the motions, increase the bowel sound. It is not necessary. You have a 3 liters of bile, stomach juice and the pancreatic juice coming up, and it is getting absorbed. So there is no need of stopping early enteral nutrition in these kids, in spite of the GI surgeries.
How early would you recommend, Dr. Vishnu? You're a pediatric gastroenterologist. Say you had a resection into an anastomosis or say a colostomy or whatever has been placed for a surgical issue. So you're saying that you won't really wait for the bowel sounds, like typically the surgeons say second day, third day when the bowel sounds are visible, as well as maybe radiologically you're able to see some gas shadows and you start feeds, or would you start within say 48 hours? What are the sort of guidelines for this?
So we have been starting within 6 to 12 hours of the surgery. Once he is out of the sedation and the general anesthesia. So we are starting early. And this has been practicing since last 1 year when I shifted to Jupiter Hospital, Pune. And we are seeing quite a good dramatic response because the recovery is very early.
It seems quite early. I think most of us are at least, sort of tuned to at least 24 hours, no feeding. And then after that, going on 6 to 8 hours, it seems to be quite too early actually. But I mean,
in the adult, they are doing it. All the GI surgeons are starting it, and it's just our resistance that is driving us. But the data will come out. Maybe we have a couple of patients, and we will keep it blinded and see that how it goes.
I agree with Vishnu. Recently, we have started seeing that our adult surgeons who are operating on Kasai and those they have started giving them early, and we have seen just very early to say just last 2 to 3 patients which they have started very early and there was no issues at all. But traditionally for the pediatric surgeons, they usually wait for 2 to 3 days or something and then start. But now this is the latest trend which I have seen. I was also surprised at that time, but we have seen now, and there were hardly any complications in the last 2 to 3 patients what they have started.
Yep.
There is a question. Should we take that just now? It's on what is general recommendation for starting lipid infusion in suspected and culture-proven sepsis. Dr. Prasad, will you take the question or?
I think Dr. Vishnu would be able to answer that, especially with TPN and lipids and sepsis. What would be the risk, Dr. Vishnu?
I think giving the lipid, what it will definitely do is the biofilm and the biolayer around the central lines, and then they are notorious to handle. So I would prefer to culture negative. Till that time, I would reluctant to start fat. But saying so, there are certain scenarios where you have to push for the calories. So in those scenarios, particularly in some of the kids who are awaiting the small bowel transplant, there may be a judgment to start a lipid in spite of the culture proven. It all depends on the situation, but I would be reluctant and I would wait for culture negative result till I start the lipid.
I probably agree with you, Dr. Vishnu, on that. I think probably just protein and glucose infusion and till we are sure there's no active infection before starting lipids.
If it's okay with you, I'll quickly show the guideline we had prepared in 2012 in our level 4 ICU in 2012. Bhavi, can you just allow me screen share? So this is our feeding guideline in the children's intensive care in the University of Leicester in 2012. And you can see that our guideline was just a basic A4 size, first flow chart, feed to be considered within 6 hours of admission. Trophic feeds to start ASCP to 8 with gut priming. To aim was to reach BMR within 5 to 7 days. NJ feeds to be preferred over TPN if gut is not functioning but poor tolerance is observed. PN should be targeted for BMR is not reached within 5 to 7 days. So we would start a parental nutrition, and remember this is in 2012 we had made this guideline. We would not start PN until they were 5 to 7 days later. And this is where we have the author is myself, Sarah the dietitian, and Alison the pharmacist. So this is what we were doing. And this was where we said that we will start and push feeding within 6 hours of admission into ICU and keep TPN within 5 to 7 days. Obviously, there the feeding guideline was also mentioned, and the amount of feeds will start for the low risk and the high risk. High risk also will start about 1 ml per kg, 2 hour feeds for different weight gain. Okay, and then there was same thing, and there was some criteria for the high risk patients who are called as high risk. And based on that, we have made this guideline. So just a quick review of that, just for people to understand that even in 2012, we were thinking of, maybe waiting for the people to settle down after 3 to 4 days. It was like a basic thought process we had. When we were sick, when you are sick, you have soup and water and liquid and sit. You don't go out and start having a steak. And so, why are we giving so much protein to this patient on first 2-3 days? And when we know that when they are in a sick state, they do not go into anabolic phase. You have to just prevent catabolism by giving them enough glucose for energy, while they are not going to go into anabolic phase when you are like this. So, that was where our thinking was coming.
There's a question, Dr. Amish, for Dr. Vishnu from Dr. Jaisal. How do you recommend and optimize pre-transplant nutrition? That's one of the questions she has.
I hope it is regarding the liver transplant, because in the liver transplant, what you need is the MCT diet along with a good energy, which is more than what is the requirement. Say a 6 kg child not only needs 600 calories, but it needs at least 800 to 900 calories with good protein and a good amount of MCT based diet. And we in India, we are struggling with the MCT diet. We increase the MCT based diet and there is a lot of diarrhea. So we have to keep a balance between them and give a good amount of protein. There is no protein restriction which is required. And I think if the child is not taking orally, we try to increase the energy in the small amount by adding multiple things and the high calorie dense feed. Or if the oral intake is really poor, then we put the nasogastric tube and then feed through the nasogastric tube. Especially we have a system called as a nighttime feeding, and that we are practicing in India also, that giving the pump to the patient which we have bought in the hospital on the rent basis, and throughout the night the child is fed through the pump, and in the daytime then whatever is amount is ingested. So we keep a balance of that, and it, in spite of a good calorie and protein, it is very difficult to gain weight because they have such a high catabolic state that it is difficult. So sometimes in some of the kids we needed to give a TPN along with the enteral feed to increase or optimize them before the transplant, and it is a Herculean task, I must say.
So to optimize means what are your cutoffs there? How do you know you've optimized it? Is it just a calculation based, or do you get some weight is too far away, I'm sure, to get an answer? How do you decide this is optimal?
Yeah, actually, the basic idea of optimization is that once you optimize, one is the weight gain, second is the control of the protein, the albumin gets up. So if you can able to sustain the albumin more than 2.5, you will optimize that child. It is very difficult to reach to 3.5 in the liver patients. So it is basically the 6 kg child, if it grows to the 9 kg or 10 kg and with good muscle mass, then you will be having a good result post transplant. So that is the basic idea of making it optimized, but it is very tough. Once the liver has started failing and then you are going to optimize, it is a double-edged sword.
Lakshmi, Neil has made a very good point. Want to read that?
Yeah, so even I was considering the same thing, that often we think that let's at least give PPN. No, we want to give glucose and we want to give amino acids. We keep away the lipids. And whereas if you looked at the graph that was shown where all the red blocks were from the amino acids, so that is what Neil has also commented, that the study showed most harm with proteins and not with lipids. So there were more infections with parenteral nutrition. So he's still asking, are we sure it is lipids which is the villain for infections in TPN? Hence, the above question also is, should we keep away from lipids or should we give lipids? Do they have a better, are they protective versus studying all these amino acids? Do they cause more inflammation? What is it with amino acids?
Yeah. Prasad, you want to take it?
Add anything to that sentence which I read?
I think probably Dr. Vishnu will be able to enlighten us about lipids earlier on or probably a little bit later on. Most of us have the practice of starting just glucose initially and then adding on some protein in a situation where, and lipids a little bit later on. And quite a few patients, honestly, in our unit, most patients with just amino acids and glucose, they've been able to tide over the first difficult 3 to 4 days. Eventually start enteral nutrition and then establish enteral nutrition. I agree, they might probably have lost some weight and they must have had some catabolism. But the risk of infection and other complications are much less if you probably delayed lipids. I don't know what your take is on that, Dr. Vishnu.
I think the question which I answered, that in the culture proven sepsis, or when you are suspected to have an infection, so if you give a lipid, so lipid tend to have a biolayer or biofilm along the catheter, right? So if this is no infection, then the lipid you can give as from the first day itself. Protein, why the protein is the problem is probably the SRS response is more with the protein. And I'm not sure about the lipid increases the risk or the protein increases the risk. The jury is still open. Some people feel that the lipid is the culprit. Some people now think that the protein is the culprit. But if there is no infection, then everything should be given. If there is infection, I would reluctant to give lipid at present. Maybe down the line we might change according to what evidence we will gather in the next few years.
Yeah. So we'll go to the next case presentation.
Yes.
Can you allow me to share my screen, Dr. Ramesh?
So you can share your screen.
In meantime, Lakshmi, you just want to introduce Bhavik, or Parmanand, you want to introduce Bhavik, please?
Dr. Biradar, you mean, no?
Sorry, Dr. Biradar, yeah. Sorry. Lakshmi, you take over, yeah.
Okay. So welcome, Dr. Biradar. He is presently working as a consultant pediatric gastroenterologist and hepatologist at Jupiter Hospital in Pune. And he has published many papers and publications in international and national journals. And he's also gotten the International Travel Exchange Award in 2018-19 from ESPGHAN. Welcome, Dr. Biradar.
Thank you.
Sorry for the confusion, Dr. Vishnu Biradar.
No.
All yours, Dr. Prasad.
First, I'd like to thank the IAP Mumbai Intensive Care Chapter for inviting me to participate in today's program, particularly Dr. Amish, who contacted me about couple of weeks ago. So my topic today is just about a case presentation of a typical child in the PSU who's needed parental nutrition for a relatively, not a very short time, but a reasonable length of time. We had a 4-year-old child who presented with the history of severe abdominal pain, fever, and vomiting for 3 days to the emergency room. The history of poor feeding and decreased activity since 1 day. In the ER, our fellows evaluated the patient. The patient was obviously quite sick with increased work of breathing and circulation being abnormal and appearance being abnormal. So the categorization was unstable and life-threatening. So they went ahead and did what they had to. The primary assessment showed the airway was open and stable. The child was breathing at 36 breaths per minute, normal efforts, and saturations were 92% room air. However, the child was a bit tachycardic, 138 per minute heart rate, blood pressure, borderline 70 by 36 with a mean of 44, and capillation quite prolonged. The child's peripheral pulses were quite feeble, and the ECG rhythm showed a sinus tachycardia. GCS was 12 by 15, and pupils were normal size. Blood sugar was 83 at admission, and the child had a temperature of 102, and the skin was quite normal. There was no flushing or any rash as such. So he was stabilized as per standard PAS protocol. He was given a fluid bolus, given oxygen by NRM, and then evaluated once the child became stable. Upon evaluation as both laboratory as well as imaging, it was found that the child had acute necrotizing pancreatitis with a perforation. So once stable, the child was transferred to the PSU for further care. And as per the surgeon's opinion as well as our own assessment, we had planned to keep the child NPO for the next at least a week, maybe 10 days or even 2 weeks. So some recommendations about parental nutrition and for initiation in children. Typically, whenever the intestinal tract is not functional, I think in this child, particularly with severe pancreatitis and a perforation, it's more or less a no-brainer that we're not going to feed the patient in the next few days at least. So we had to initiate some form of parental nutrition relatively early to cover the child's nutrition needs. Other recommendations for vascular access. I mean, our administration is something which we need to make sure that is done as safely as possible. If you have a double lumen or a triple lumen line, it's invariable that one line of the central line should be dedicated only for parenteral nutrition. And typically in our unit, we practice once in 24 hours, the solutions are hooked up and broken into, the line is broken into just once in 24 hours, just to reduce the risk of infections. As intensivists, you know, the sites with the least risk of infection is away from the lower part of the body. Typically, the internal jugular or say subclavian is relatively more safer as compared to femoral site for obvious reasons. Before starting, we need to verify the position, make sure the distal position of the catheter on X-ray or by ultrasound lies in the appropriate place. And typically, just with the SVC junction, right atrium junction would be ideal for the internal jugular vein catheter. Just an X-ray representation of what we aim for. The tip of the catheter should be somewhere here, SVC right atrium junction, and verified by both radiology and also probably by point of care ultrasound, which we can easily do nowadays. We have quite a few products, but I think the ones that are available in India mostly come under the double lumen or triple lumen type of solutions. The Fresenius Cavi is the one that's available to us frequently, and we tend to use that more often for total parenteral nutrition. Components of TPN solutions, I think the protein component is as crystalline amino acids and fats as lipids, intralipid as I would say. The carbohydrate source is as glucose. And apart from the macronutrients, the electrolytes, sodium, potassium, chloride, calcium, magnesium, and the trace elements, zinc, copper, manganese, chromium, selenium, these need to be given. Particularly more important in those children who are going to be on parenteral nutrition for an extended length of time. Apart from the trace elements, the vitamins, especially the fat-soluble vitamin A, C, D, K, thiamine, riboflavin, and other vitamins need to be provided. And of course, if you're using a central line, you need to use heparin to keep the line patent. And of course, there are other medications apart from the parenteral nutrition itself. You have to account for medications, the antibiotics, the flushes, as well as other solutions which go through the line. These, I think, we are quite know about this, the process of calculation for total parenteral nutrition. First is to calculate the fluid requirement as per the age and weight and the nutrition status, the lipid and protein requirements, and then the volume required for infusing the lipid and protein. Out of the total fluids that we need to administer to the child in a 24-hour period, we have to deduct this. The remaining fluid you need to take into account for provision of glucose, what concentration, whether it's going to be 10% or 12.5% or more, depending on the amount of calorie requirement we are going to give for the lipids. And then we need to add the micronutrients, electrolytes as needed, characterization, and of course heparin for keeping the line patent, and 1 unit per ml is what's recommended. This child weighed around 15 kilos and had a height of 98 centimeters. So we secured central venous access for provision of TPN through the right internal jugular vein, which was placed successfully. On the first day, we calculated a total fluid requirement of 1,250 ml as per the Holiday-Segar method. And the energy requirement was, as per the WHO equation, was 850 kilocalories per day. As per the requirements of protein to start with, amino acids 1 gram per kg per day, which amounts to 15 grams. It amounted to about 10% of 10% aminoven, 150 ml. The lipids, 1 gram per kg per day of 15 grams, 20% interlipid, 75 mL. The recommendations are in infants, you can start with 1 gram per kg, but advance gradually and go up to a maximum of 3 to 4 grams. We are familiar with this sort of a calculation, typically in preterms as well as neonates who need to be kept on TPN for a lengthy period of time. In the older child, we start at 1 gram, advance gradually, little slower, 0.5 grams per kg per day. Eventually, we limited at 2 at the maximum of 2.5 grams per kilogram per day, once we reach the final volume. The lipid required as per the recommendations in infants, we start with 1 gram, gradually advance, and then reach 3 grams per kg per day. But in the older child, up to 2 grams is what's recommended, not beyond that. And we go up a bit slower when we go up on the lipid concentration. Dextrose requirement, the requirements are approximately the same in the older child, 5 milligrams per kg per day, but the maximum limit of 8 mg per kg per minute in the older child as compared to an infant or a neonate, where you can go up to even 10 to 12 milligrams per kilogram per minute. That's the GAR, or glucose infusion rate. Electrolytes are more or less pretty standard. Sodium, we need 3 milliequivalents per kg per day of sodium, 2 milliequivalents per kg per day. Calcium, 2 milliequivalents per kg per day. Magnesium, 0.3. And multivitamin injection, 1 ml per kg per day. So if you look at the volume that had to be added to the TPN solution for this patient, it worked out at approximately 10 ml of 3% normal saline to achieve the 3 MEQs per kg. 15 ml of KCl and 66 ml of 10% calcium gluconate and 1.1 ml of magnesium sulfate and MVA 15 ml. The multivitamin products which we generally are available is MVI pediatric, which contains the required recommended daily requirements of various components, A, D, E, K, vitamins, C, thiamine, riboflavin, niacin, and other elements. And the Baxter version, the Inflovite Pediatric, which has got slightly almost similar values, but very, very similar to that of the pediatric MVI. In our unit, we use the pediatric MVI. So as per the calculation, we had to 1250 was the volume to be infused. So including additives, everything, we had to give about 920 ml. And the amount of glucose per day worked out to about 129.6 grams per kg per day of dextrose. This calculated making a stock solution of 10% dextrose, 800 ml, adding 100 ml of 50% dextrose and distilled water, 20 ml, and energy from dextrose, which we derived from this calculation, was 440 kilocalories. So the child was pretty stable for the first 2-3 days after we started TPN. On the third day, the child became a bit lethargic. And at that point, we found a GRBS of 50 on one occasion, a bit lower than that, close to 40, 38 on one occasion. This is one common problem which we face in children who receive TPN. Hypoglycemia was obvious, and we had to increase the glucose infusion rate to 8 milligrams per kg per minute from 6 milligrams per kg per minute. Thereafter, the values are reasonably stable, and we're able to stabilize as well as maintain euglycemia. Growth monitoring as per the recommendations for children with TPN. In infants and neonates, typically we are used to weighing them daily, but in children and adolescents, twice a week should be reasonably fairly sufficient. And in case the child has got intestinal failure or other reasons where we have to have provided home TPN, monthly at least minimum, I would say probably once a week or once a fortnight for children and adolescents would be more appropriate. Length of night for neonates is more or less weekly, but for older children and infants, once a month. Head circumference in neonates, which is relevant, is weekly, but less than 3 years of age, once a month should be sufficient. And once a month for those who are on home parental nutrition, who are less than 36 months of age. Now, there's something where there's a little bit of variation in this about laboratory monitoring when a patient is on TPN. Typically, initially, we tend to test more often till we are confident that things are stable. The typical biochemistry panel of BUN, creatinine, electrolytes, acid-base status, we do it daily, but say by the 3rd, 4th day, things are relatively stable. You can do it in just once every alternate day or just twice a week as required. And liver function tests, again, initially at baseline and then weekly. triglycerides weekly later on, but initially you might need to do it a bit daily. CBC differential against initially, first few days you might want to do it daily, but then after that, once things are stable, the frequency become less. The other trace elements, vitamins, can be as clinically indicated, and this can be as per the patient's condition. The vast majority of patients where we withhold feeds and resort to total parenteral nutrition, generally I would say I don't have any accurate numbers, but most patients within a week, we're able to transition them on to enteral feeding and stop TPN. So the requirement would be 4 to 5 days, or maybe about a week maximum, rarely beyond a week. So in this patient with the severe pancreatitis and perforation, we had to continue for more than 10 days. On 10 days, typically he had the what would you expect is fever spikes with hemodynamic instability. Sepsis workup was initiated, antibiotics were escalated, and CRBSA was suspected. We were able to manage for 48 hours with the central line in place, but after that we had to remove it and then manage with the peripheral IV. The most important thing for prevention of infectious complications, I would say, is hand hygiene. Point of contact with the skin, the line, as well as the surrounding areas is of paramount importance. And I think not just physicians, actually we might be the most negligent as compared to a nursing staff, following a rigorous protocol, hand hygiene protocol, making sure there's no touch, no skin contact with the line as well as the hub, as well as the entry point is most important. Of greatest importance would be during the placement. At most, care should be taken during the placement of the line itself. Absolutely sterile technique following the full gown mask, the draping, making sure you have a wide area which is sterile so that you don't minimize the chances of contamination at that point in time. And if you don't really need many other drugs or infusions going in for that particular patient, even a single lumen catheter dedicated just for parenteral nutrition is good. And try and use the line as minimal as possible and breaking into it, and use a different line if you have to take blood samples. Tubing changes for dextrose, amino acids, intralipids, if possible, once in 18 hours, 24 hours, that will decrease the risk of infection. And when you're actually accessing the line and trying to break the line, again, the standard precaution, just like how you followed the precaution when you inserted the line, the same should be followed. If possible, try and avoid a multi-lumen catheter. And this is what we said, catheters in the groin diaper area, especially in infants and children, it's obvious that that area is contaminated. The bacterial, skin bacterial flora would be much higher in numbers, as well as the risk of contamination is very high. Try and avoid that. So if you need to, you can even go for a PICC line placed in the cubital fossa or axillary, and preferably an IJ or a subclavian if possible. The preparation of the solution itself should be under a laminar flow system with strict aseptic precautions. All these would reduce the risk of infection. In this child, we had to continue the total parenteral for close to 3 weeks. Around the second week also, the child developed a bit of jaundice and was passing a bit of high-colored urine. I know we can assess and also diagnose what this condition is all about. Parenteral nutrition associated liver disease. We call TPN cholestasis commonly in the casual way of saying that. But the diagnosis for this is characterized by a raise in serum direct bilirubin of more than 2 milligrams per kilogram, or histopathology showing a moderate to marked fibrosis, prolonged exposure more than 2 weeks to parenteral nutrition. We rarely have to resort to a biopsy for this, but once we note parenteral nutrition liver disease, we generally try to reduce the lipid and change the infusions. This condition also includes hepatic steatosis, cholestasis and cholelithiasis. However, in children, mostly steatosis, most common in children. There is a direct association with the development of PNA-LAD, and the duration of TPN. Fortunately, in most situations, we rarely have to resort to parenteral nutrition for more than a week, 10 days, or maybe 2 weeks in most situations. It's exceptional to require TPN beyond 2 weeks in most pediatric ICUs. Certain strategies or approaches to reduce the risk of liver disease related to parenteral nutrition is to reduce the have a balanced macronutrient profile, 50 to 60% of the calories coming from carbohydrate, 10 to 20% from protein, and 20 to 30% of lipid. We should also avoid overfeeding of macronutrients calories from parenteral nutrition, reduce the soybean oil predominant lipid emission to 1 gram per kg or as appropriate, and to consider alternate lipid emissions. And cycle less than 24 hours, maybe you can give it for 18 hours, give a gap, and then again continue with TPN the next day. And as the saying goes, as early as possible, medically appropriate. Once you feel the child is ready to receive enteral nutrition, go ahead and start trophic feeds as early as possible, transition to enteral feeds, and then slowly wean off and discontinue TPN as early as possible. So in the 4th week, this child, we were able to start feeds, and once the child's feeds were tolerated, about 3 to 4 days, we're up to close to 50% of the child's nutrition volume that is required. We discontinued the parent nutrition and then removed the line. A few strategies before I end my presentation for parent nutrition is: one is to optimize parent nutrition in the ICU, dosage of lipid to be restricted, initiate early, advance stepwise, and have prudent goals, not overfeed. Don't give too much protein initially, and try to individualize for that particular patient. There's no sort of a goals written in stone that you need to do it exactly the same way as per protocols which are available for an individual patient. If you can customize it for that patient, that will be great. And as soon as possible, every day, try to see and think, when can I get rid of the catheter? When can I switch to enteral feeding? Most important is catheter asepsis, especially during the time of insertion and then during the maintenance. This is where the nurses need to realize that they are entirely responsible as well as accountable for infection prevention. As physician and intensivists, we are there during rounds, in between when we come back and check on the patient, and rarely at night when most senior intensivists go home and the fellows and others look after the patient. Ultimately, when solutions need to be hooked up through the line, central line, or a TPN needs to be hooked up, it's most often the nurse alone who is available there. Maybe 2 nurses who do it, and they have to be taught how important it is not to break the infection protocol. Most important. And of course, monitoring. Thank you. Thank you for it.
There are no questions which have come up.
So very interesting case, Dr. Prasad, and very well explained about everything. Vishnu, you want to make any comment?
No. We see a lot of issues in the pancreatic patients, and as was rightly said, if it is needed, then the strict asepsis is the crux. And what we have observed also, the physicians are the more reluctant people to wash the hands, and they go there, they touch the file, they touch the bed, and that increases the chances of asepsis. So it has to be compulsory to wash and then go to the nearby to the patient. Even you don't touch the patient, but you touch surroundings, and that is the needles for the infection.
I would just ask, Lakshmi, I'll just ask one question to
Yeah.
Dr. Prasad and Dr. Vishnu. So are we seeing less PNLD after we started using lipid, or is it just that compared to before, or is it any papers or anything which says that, or it's just our numbers are so low that we don't know yet?
Dr. Vishnu?
Yeah. With the SMOF, we see a less number of TPN associated cholestasis.
Yeah. So I feel that is a very valid point what Dr. Prasad was making about using the SMOF lipid nowadays, especially when we need to use it.
So in our unit, we don't do transplants. So generally speaking, the parenteral nutrition are mostly for those kids post-surgical or those who have had severe complications secondary to liver disease, medical liver disease. So in most children, less than a week, we rarely give beyond a week of TPN. At least in our unit, that's the population that we deal with. But I think our units which deal with more complex disease, I think from the cardiac standpoint, as well as those who have impaired GI systems, children who need prolonged periods of parenteral nutrition, they might face these problems a little bit more often as compared to units which don't use PN for too long.
Any other comments, any other questions from anyone? One very important point which you made was about laminar flow. So it is very important. Do you want to highlight about that laminar flow for people to understand that they should not be making TPN without a laminar flow, sir? You made a very good point about TPN and laminar flow.
Right from the preparation to the point of actually connecting the parenteral nutrition to the central line, every step I think is equally important where we need to make maximum precautions. And that will minimize the risk of sepsis and infection and complications as time goes by.
So there's one question. How long will PNAD take to reverse? So Dr. Vishnu, would you answer that?
Yeah, I think in the early stage, if it is not gone into the fibrosis, then the stopping the TPN within 2 weeks to 3 weeks, we see is a reversal. And if it is a long TPN associated cholestasis, especially in the newborn, I would like to tend to rule out the other causes of neonatal cholestasis if it is persisting. And many times those patients who are ablated, particularly the jejunal atresias, the proximal jejunal atresias operated cases, they tend to have a cholestasis with the TPN because of the some unknown reasons, but usually it gets reversed within 2 to 3 weeks. We rarely see in the small bowel transplant settings in the UK. When I was there, I used to see that patients are TPN for years together without having much of TPN related cholestasis or the liver disease. But some of the kids who develop this then land up with the chronic liver disease and they need a liver and small bowel transplant together. But nowadays, because of the cycling of the TPN, the duration has been decreased, the SMOF has been came into the play, and little bit of enteral plus parenteral is the key that it just avoids the TPN related cholestasis.
Yeah, okay. If there are no other questions, are we Amish, what is the plan?
Yeah, the vote of thanks, please,
You
Lakshmi.
can
Carry
go
on.
ahead.
Yeah.
So thank you, Dr. Prasad, for explaining and taking us through that case with so much detail. Including those calculations in your presentation. It is so important to learn those, and often you teach them to your students and your residents. So it was really nice of you to go to that depths also. Dr. Vishnu, for taking out your time, even in the traveling car, to be answering our questions. Thank you so much. No, it's really appreciated. You are going beyond you have really taken out your time for us. Thank you very much. Dr. Shasha, I know you're not with us just now, but thank you for accommodating us and doing the presentation for us as a recording. Thank you so much, everyone. And I hope everyone enjoyed this CME lecture on food for thought, made you think, and maybe we will do something more better for our patients with this knowledge. Thank you. Thank you, Amish. Thank you, Dr. Parmanand.
Thank you.
Right.
Thank you, Vishnu. Thank you,
Thank you.
sir.
Thank you.
Thank you, Prasad sir. Thank you, Vishnu. Thank you, Diya.
Thank you, sir. Thank you.
Thank you, everyone. Thanks, Prashad. Thanks, Vishnu.
Thank you, sir. Thank you for being with us.
Thank you, Dr. Minaj.
Thank you.